Okay, now let's look at the drugs. What are the drugs used as antacids? So what are the drugs which are currently used clinically as antacids? So before we discuss that, let's have a small recap. So we said that there are certain drugs that alter gastric pH. Okay, that alter gastric pH. And one example of that we said was hydrochloric acid. Okay. So we said it was given in echlorhydria. So then we said that antacids are drugs which alter the pH. In defining antacids, we said antacids are drugs which um, react with the hydrogen ion, the proton, and thereby alter gastric pH without interfering with the volume of the gastric secretion. Okay. So the second class of drugs that alter gastric pH are antacids. So this is the big picture. Okay, so pharmacologically, we got drugs that alter gastric pH, and one of the drugs is hydrochloric acid, which is given for the treatment of echlorhydria. And the second class of drugs which alter gastric pH are antacids. Okay. And we said they are used in dyspepsia. Dyspepsia, heartburn, okay, and the other indications we have seen. So let's see what are the mechanisms of action of antacids. So we said they directly alter the pH, but that is not the only mechanism of action. So let's write here the mechanism of action. Which we abbreviate MOA. So the mechanism of action of antacids. So we said the first mechanism we discussed that there was a partial neutralization of gastric acid. Okay. So this is the main mechanism of action. Okay. They cause the partial neutralization of the gastric acid. Because partial neutralization of the gastric acid. So that is the main mechanism of action. But in addition to the partial neutralization of gastric acid, they have got some other mechanism of action. Okay? So they decrease the pepsin activity. Decrease the activity of pepsin. They decrease the activity of pepsin. So let's write it properly. They decrease the activity of pepsin. So we said pepsin needs a pepsinogen. So pepsin is produced as a zymogen. It's a pepsinogen is the zymogen, the inactive form, and that is activated to pepsin by HCl. Okay. So antacids, what do they do? Antacids neutralize HCl. So as a result, pepsinogen is not converted to pepsin. Okay, so in this, so that's what we have written. So antacids, they decrease the activity of pepsin. The third thing that antacids do is to stimulate prostaglandin production. Okay. So PG is prostaglandin. So what do prostaglandins do? They increase secretion of bicarbonate, and they increase mucus production. Okay. So by this mechanism, antacids are cytoprotective. Okay. Meaning they protect the gastric mucosa from getting ulcerated. Okay, so now we know that is one of the mechanism of action of antacids. The other mechanism of action is antacids. They are usually very fine. They are in fine powder, in suspensions. They have got very great surface area. So as a result, they are able to absorb bile salts. Okay. So bile salts along with pepsin and HCl okay, can cause erosion of the mucus layer of the GIT okay, and the esophagus. Okay, so these antacids, they've got a protective role. They can, by absorbing bile salts, they can reduce the erosion of the mucus layer. Okay. So these are the this is the most important mechanism of action, and these are the other mechanisms of action. Okay. So now let's see the classification of drugs. Okay. So the classification of antacids. So let's give it a heading. Classification of antacids. Okay. So antacids, if you remember, we said that there is increased acid in the stomach, and this acid needs to be neutralized. Okay. So there is increased HCl, and this HCl, this acid, needs to be neutralized. Okay. So the HCl needs to be neutralized by these antacids. Okay. So where do they need to work? They need to work locally in the stomach. Okay. So an ideal antacid would be one that neutralizes antacids, works for a long period duration of time, and it works locally in the stomach. Okay. So that is an ideal antacid. But like everything in life, the antacids that are clinically used, they are not ideal. Okay. So some of them get absorbed. Okay. So when we say absorbed, so some antacids get absorbed. Okay. So by get absorbed, we mean that they get into the systemic circulation. Okay. Meaning they enter blood. Okay. So you take these antacids, they do their thing, they get into the duodenum, and from the duodenum they are absorbed into the blood vessels. Okay. So there are certain antacids that get absorbed, and the antacids that get absorbed, we call them absorbable antacids. And what are the examples? We've got sodium carbonate, magnesium oxide, calcium carbonate. So we could also add here as the first one sodium bicarbonate. Okay. And then there are antacids that are not absorbed. Okay. And so we call them non-absorbable, meaning they act only in the stomach. Okay. So non-absorbable, they act only in the stomach. Okay. So they are not absorbed and they act only in the stomach. Okay. So if we look at the examples of both, we can understand the generalization. So antacids, we said they are weak bases. Okay, so bases react with acids and cause salt and form salt and water, and that is a neutralization reaction. Okay, and that is exactly how antacids work. So if we look at the examples, we understand that they are basically salts of sodium. They are salts of calcium. And they are salts of magnesium. And they are salts of aluminum. Okay. So antacids are salts of sodium, calcium, magnesium, and aluminum. So let's look at absorbable. Absorbable, how did we define absorbable antacids? Absorbable antacids are antacids that get into the systemic circulation. They enter the blood. Now let's see what happens to sodium carbonate when it reaches the sodium bicarbonate. Okay, so the first one that we are writing is sodium bicarbonate. So let's look at sodium bicarbonate. Okay, sodium bicarbonate reacts with the hydrochloric acid to form sodium chloride. Okay. What does it form again? Sodium chloride and very good. carbon dioxide and water. Okay. So initially it forms sodium carbonate, and then sodium carbonate reacts with the HCl to form sodium chloride, carbon dioxide and water. So this carbon dioxide is a gas. Okay. It is a gas. Okay. Let's look at sodium carbonate. Again, it reacts with HCl. What does it form? It forms sodium chloride. Okay. Then carbon dioxide plus water. Okay. So let's balance this. Okay. Okay. So these are sodium salts, and this is what they form. And we said that they get into the systemic circulation. They are absorbed. So when they get absorbed, what happens? They cause, so you see there is lots of sodium. Okay. So if they get into the blood, they can cause, potentially they can cause sodium overload. Okay, they can increase the amount of sodium in the blood. And what can happen if sodium increases in the blood? Yes, very good. There can be water retention. Again, water retention can increase blood pressure, and increased BP can lead to heart failure. Okay. So there can be sodium, there can be overload of sodium. Okay. But the first thing that happens is we administer it orally, per oral. Okay, so it's given orally. As soon as it reaches the stomach, it neutralizes the acid. So there are some good things happening also. Okay. Yeah, so there will be sodium overload, there will be water retention, as well as, because it is bicarbonate, this bicarbonate also sometimes gets absorbed, and it can cause systemic alkalosis. Okay, meaning the blood will become alkaline. Okay. So these are the negative things that happen when it is systemically absorbed. So these are the systemic side effects. Okay. So systemic side effects are side effects which happen at the therapeutic dose. Okay. And what are they? There can be sodium overload, and that can lead to water retention, and that water retention can increase the BP, and it can lead to increased chances of heart failure, and it can cause systemic alkalosis. Okay. At the same time, in the GIT we said it's given per orally, it acts with hydrochloric acid, and then what happens? There is this neutralization reaction. So the neutralization reaction is very fast. Okay. Typically it takes less than 10 minutes. Okay. In less than 10 minutes, they reduce the, they cause neutralization, and they increase the gastric pH. Okay. So sometimes up to 7. Okay. So approximately the gastric pH is about 1.5 to 3, and this gets it increases to 7 within 10 minutes of administration of bicarbonate. Okay, but it has got this problem. Okay, it can cause systemic side effects. Okay. Okay, so these likewise magnesium oxide can react with HCl. Okay, can form magnesium chloride, calcium carbonates, again can form calcium chloride plus carbon dioxide. Okay? So you get the idea. So in that process, in this neutralization reaction, what happens is the acid gets consumed, and as a result the pH increases. okay, and that is um, absorbable um, antacids. Okay. Now, if magnesium gets absorbed, what's going to happen? If magnesium ion gets absorbed, um, it can cause sedation, it can cause bradycardia. So what is bradycardia? It is decrease in the heart rate. Okay, it can cause bradycardia. It can reduce blood pressure. Okay, and it can make the person lethargic. Okay, meaning the person will lose all the mood or enthusiasm, and then there will be loss of deep. Say, let's write loss of deep reflexes. Okay, so this can happen if magnesium gets absorbed. So these are the systemic toxicities of magnesium. So remember, magnesium ion on the CNS, it causes CNS sedation. Okay, so that is a CNS depressant effect. Okay, and if you cause CNS depression, naturally you will be lethargic and you will lose deep reflexes. Okay, so the underlying point being that magnesium, absorbed magnesium ion, it causes CNS depressant effects. Okay. So the absorbable salt of calcium, that is calcium carbonate, it also has got certain problems. Okay. So here the in magnesium, the onset of action is kind of slow. Okay, so the onset of action of magnesium salts is slow, meaning it takes more than 10 minutes for it to act. Okay. Calcium carbonate, it is faster than magnesium salts, but it has got this it has got its own problems. Okay. So if you look at calcium carbonate, again it forms calcium chloride. Okay, and it forms carbon dioxide and it forms water. So this carbon dioxide is a gas, and what happens to the gas is that it can cause belching. Okay. So all antacids which produce carbon dioxide they can cause belching, okay, which is basically the eructation of gases. Okay, with typical sounds which is not very socially acceptable in certain cultures. Okay. Right, so that's one of the problems with um, calcium carbonate. Okay, calcium carbonate has got another problem. Calcium carbonate can stimulate. So calcium carbonate can stimulate the release of gastrin. Okay, so in the previous lectures we said that gastrin acts on the G cells and it stimulates hydrogen, potassium ATPase, and it causes secretion of protons. Okay, so that is the action of gastrin. So calcium carbonate can stimulate gastrin. So we are giving it as an antacid to reduce the effect of the acid. So as soon as it reaches the stomach, it will neutralize the acid that is present in the stomach. At the same time, it will stimulate the gastrin receptors. And by stimulating gastrin receptors, they can increase the gastric secretion. Okay? So this is called gastric acid rebound. So acid rebound can occur when calcium carbonate is given as an antacid. Okay, so that is again another side effect of calcium carbonate. It can cause calcium rebound. The other thing that it does is calcium carbonate, it can stimulate the GIT, and by stimulating the GIT, it can irritate the GIT. Anything that irritates the GIT can cause nausea and vomiting. Okay. So calcium carbonate can cause nausea and vomiting. So we said calcium carbonate gets absorbed. So if calcium carbonate gets absorbed, it can also cause systemic alkalosis. Okay, and remember, calcium is getting absorbed, so it can cause hypercalcemia, meaning the concentration of calcium will increase in the blood because it's getting absorbed into blood. Okay, and this hypercalcemia can result in something called milk alkali syndrome. Okay, so milk alkali syndrome is the presence of hypercalcemia, alkalosis, and renal insufficiency. Renal insufficiency. Okay, so it can cause a cluster of symptoms: hypercalcemia, alkalosis, renal insufficiency, to mention a few. And this cluster of symptoms is a syndrome. A cluster of symptoms produces a syndrome, and this syndrome, which is caused by calcium antacids, calcium carbonate, is called milk alkali syndrome. Okay. So now, what are the adverse effects that we talked about? We talked that it can cause belching. Okay, it causes stimulation of gastrin, and thereby it can cause gastric rebound. It causes nausea and vomiting, and it produces systemic alkalosis. Okay. By getting absorbed into the blood, it causes an increased concentration of calcium in the blood, which is called hypercalcemia, and it can cause milk alkali syndrome. Okay. Okay. So these are the main adverse effects that we need to remember about calcium carbonate. Okay. Okay. So let's look at the other non-absorbable antacids. Okay. So the non-absorbable antacids, if you look at it, they are basically aluminum salts and magnesium salts. Aluminum and magnesium. Okay. So they are not absorbed, so they act primarily in the GIT. So in the GIT, they have got certain special characteristics, certain specific pharmacological actions. Aluminum in increased doses can cause constipation. Okay. Magnesium, on the other hand, they cause laxation. Okay, so aluminum can cause constipation. What is constipation? Decreased movement of the GIT, which results in decreased bowel movements. Okay, so aluminum salts can cause this decrease in bowel movements. Magnesium salts, on the other hand, cause laxation. So therefore, these two drugs are combined. Okay, so aluminum aluminium salts and magnesium salts are combined. Okay, and this combination has got lots of proprietary medicines in the market. Okay, but they contain aluminum salts and magnesium salts. So one is constipating, one is laxation. So let's understand why we combine. Okay, so let's learn the rationale of combining. Combining aluminum and magnesium salts to be used as antacids. Okay, so there are two main reasons. So the first reason is that aluminum has a fast onset of action. Okay. Magnesium has got a slow onset of action. Okay, so if we give it as a combination, what can happen? Aluminum can immediately act as an antacid. So the patient will feel immediate relief. Okay, and then magnesium takes over, and it has got a slow onset of action, but it has got a very good antacid efficiency. Okay, so that is one reason why aluminum and magnesium is combined. The second reason is to counteract this adverse effect. Okay, so aluminum causes constipation, magnesium causes laxation. So the combination counteracts the adverse effects of magnesium and aluminum. Okay, so magnesium causes laxation, aluminum causes constipation. So if we give it as a combination, they will counteract each other. Okay, so there won't be more laxation or more constipation, but there will be their action as antacids. Okay, okay. Aluminum, we have seen, if they are absorbed, they have got the adverse effect that we mentioned earlier. Okay, but remember, aluminum as a hydroxide salt and magnesium as hydroxide and silicate, and aluminum as phosphate, they are not absorbed at all. They have got only local action. Okay, so it is a better drug. Okay, so they are given. So they are used as non-absorbable antacids. Okay. There is another important point that we need to remember about aluminum. Aluminum can be easily excreted from the kidneys. Okay? Magnesium is difficult. So therefore aluminum salts can be given in patients. So therefore it can be administered to patients having kidney insult. Okay? They can be given in patients with renal compromise. Okay? Okay, so they can be given in patients who are renally compromised, who are having renal failure. Okay? Whereas magnesium salts, magnesium, it is very difficult to be excreted by the kidney, and therefore it can take, it is contraindicated in patients who are having renal failure. Okay, so that's one small thing that we need to remember about aluminum. So the other point that we need to remember about aluminum is that aluminum can bind phosphate. Okay? Aluminum salts, okay, except aluminum phosphate binds phosphates, okay, which can be excreted easily. Okay. So aluminum salts except aluminum phosphate is used in hyperphosphatemia. Okay. 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 So um, um, yeah. So we have talked about most of the antacids. Okay. So we have discussed the classification of drugs which are used as antacids, and we said that they are classified as absorbable and non-absorbable, and we've talked about important points to be remembered about these drugs.